So if you can present, I appreciate.
Sorry, could you repeat?
I sent to my presentation. So
I will share. Okay, I will share from here.
okay.
Perfect. Thank you so much. Okay, I see Askar who's joined, and I've also put Lindy. So Askar, do you want to unmute?
Hello. Hello,
Hi.
Monica.
Hi, good to see you.
Good to see you too. Yes.
Okay, good. No, just to check lighting, and it's a bit dark, but it's fine.
I will move the lamp.
Okay, so we can see you. Just testing that.
Yeah, it was a interesting interface of Zoom before, so I didn't find where to unmute myself. But this one is normal.
We have to promote you to panelist before. So that's what we're trying to do right now. So good. So now you're a panelist and we can see you. That's great. So then if you could mute yourself, I will look at the other panelists.
Should the video be on all the time, or I can...
No, you can switch it off. Up to you, whatever you're comfortable with.
We start at 3 p.m. Okay.
Yeah, we start at 3. Thank you, Askar. Lindy, would you like to unmute yourself? Hi. Okay, Lindy, can you hear us? Lindy? Okay. All right. So for the attendees who've joined, welcome. We will start as scheduled at 3 p.m. So please bear with us patiently till then.
Hello everybody, greetings to all of you who decided to join this webinar. It's a joint webinar, joint effort, so with Stop TB Partnership and WHO, and we are here with the Global Fund and all our key partners. We decided to organize this webinar to keep you informed with the vision, to keep you informed about ongoing activities, about our response to these new threats, and how we are jointly providing continuation of our essential services. So, and we would be happy also, we'll be happy to respond to all your questions, to comment on your concerns. So our joint work is continuing despite of all the challenges, and we're supporting strongly those who are at first front of the fight against COVID and continuing essential TB services. So let's start, and I'm giving floor to my very good friend and colleague, to Dr. Lucica Ditio. Please, floor is yours.
Thank you very much. It's really a great pleasure to be here. It's also amazing to see that we are 191 already. The target is to get 300. We had yesterday a bit more than 300 because we want to make sure that messages are very wide shared, and you know, people are aware of what's going on, and we can discuss together. We are very grateful and happy because we are joined today by Dr. Ren Mingui, the ADG from WHO. We are joined by our colleagues from Global Fund, led by Dr. Sam Cooney and Eliud, the senior advisor. And we are also with a lot of our friends, colleagues and NTP managers, as well as, I would say, the most important donor in TB space, USAID, and I want to recognize Dr. Sherry Vincent here in the audience as well as a lot of you from all around the world. This seminar is identical with the one that we had yesterday, and we especially tried to make sure that colleagues from Europe, Africa, and America as continents are having a better time to join. But of course, we might have colleagues from other parts of the world that joined us today, and so on. So it's we are not living easy times, but and we need to be smarter than what's going on. And it's not easy because there are a lot of things we don't know with this COVID, with what this COVID means for our health systems, for our health, for our people, what it means for TB. But we all do all our best. We are all together in this, and we are here to support you. So let's go ahead with the webinar. Thank you very much.
So great to see the growing number of participants of this webinar. So with it, I'm immediately giving floor to Dr. Ren Mingui, WHO Assistant Director General for UHC Communicable and Non-Communicable Diseases. I know, Dr. Ren, that you are extremely busy. Appreciate a lot your time that you decided to support, to join us today, and it means a lot for us. And would like to remind also, dear colleagues, participants of the webinar, you have, if you look at your screens, you have questions and answers box and option. Please put your questions, and I'm here with the whole team, Lucica, also with the team from Stop TB Partnership. We will try to respond to your questions as proactively as possible. Thank you. Over, and floor is yours, Dr. Ren.
Thank you very much to Lucica and to the Teresa and all the participants who joined this very important webinar in this very unique circumstances. And we all know it's been 3 months since WHO declares the public health emergency of international concern over the outbreaks COVID-19. There are now over 3 million confirmed cases and over 200,000 deaths globally. This pandemic has overwhelmed health systems everywhere, devastated society and economy, and exposed critical vulnerabilities in global pandemic preparedness. WHO is fully concerned that pandemic is starting to compromise access to the essential health services for both communicable and non-communicable disease. we are receiving increasing reports about the severe disruptions to prevention, diagnosis, and treatment programs for HIV, TB, malaria, and the neglected tropical disease, NCD, as well as report of stock out of essential medicines and diagnosis for these major diseases. In general, there are services disruption has some cause behind the scene. First, probably reason is the suspension of community-based activities such as active case finding and mass treatment programs and distribution of banners for malaria, outreach to the most affected population because the lockdown, physical distance, and other prevention measures for COVID-19. And the second disruption is because of manufacturing and the shipment of medicine, diagnosis, and other health products due to the travel and movement restriction, and in some cases, due to the decision by the manufacturer to shift production completely to the COVID response products. And finally, the fact that the health systems, including the majority of health workforce around the world, is undergoing major programs or repurpose of resources to respond to COVID-19. So in this way, the pandemic is absolutely disrupting the whole of the society approach we had in place for many communicable diseases in the past. There's no question this disruption will lead to the rise in associated morbidity and mortality. We have observed, unfortunately, there are some jobs in TB case detection and confirmed report cases in some high TB burden country. You might have this information from some speakers or maybe from Teresa. And you may also see some of our modeling papers for the malaria in which we concluded, according to the worst case scenario, malaria deaths could double this year compared to the baseline in 2018. So the modeling work, of course, for TB is also underway and also in other areas to give us the best, to give us scenario how exactly the disruption in terms of essential service might bring to this community and to the global. This is an absolutely unprecedented crisis, and the country needs to make a very tough and sometimes difficult decision to balance the demands of responding directly to COVID-19 while systematically strengthen strategic planning and coordination to maintain the essential health services for the major diseases and mitigate the risk of risk collapsing. Given the people living with NCD, HIV, TB, malaria, and many diseases may experience more severe disease when infected with COVID-19. So we need to redouble our efforts to protect this vulnerable population and groups. Health services, including national TB programs, need to be actively engaged in supporting an effective response to COVID-19, while at the same time ensuring that TB services are maintained and fundamental pillars of TB prevention and cares are protected. WHO is working very closely with countries to mitigate the risk. We already issue a COVID-19 special rapid guidance on the range of community disease, including TB, urging countries to continue providing essential interventions and protect the most vulnerable groups. We are now working on consolidated technical guidance for the disease-specific interventions and recommendation on how to prioritize essential services, which are supposed to be very important elements of a comprehensive plan of COVID-19 response. We are also very closely working with other partners, including the Global Fund and UNITED, to ensure continuity of services, to plan for reprogramming of disease-specific grants and funds. I'm delighted to see my colleagues from Global Fund and who joined this very important discussion. They will be providing more details on Global Fund new COVID-19's response mechanism. So I think this is a very important conversation in this very unique dimension. And we all understand TB is #1 infectious killers in the world. So we have to make sure all the actors in TB community have to work together to make sure TB will not be neglected, TB will not be completely in a siloed, and TB program have to be maintained in the comprehensive response to COVID-19. So I'm happy to have the opportunity and maybe to share, to hear your experience from the country, how exactly the issues and the challenge which I highlight can be addressed in the country context with your support. So with that, I thank you very much again for giving me this opportunity, and happy to work with you in the coming days to make sure we can end TB without any neglection and stop. Thank you.
Thank you very much, Dr. Ren. It's actually very good, I think, for all of us to hear this reassurance. We are all united here by the fact that we really want to make sure that we end TB and we achieve our UNHLM targets. And it's my pleasure to introduce now for his introductory remarks, Dr. Sam Cooney. He's leading the strategic work of the Global Fund. He was with us yesterday. I'm very grateful for your time, Sam, because I know the pressure you work under. So Sam, the floor is yours.
Okay, can you hear me? Good, okay. Good afternoon and good morning, everyone. I'd like to begin with a special thanks to Stop TB Partnership, Luchika, WHO, Ren, and others, Teresa, for organizing this very important webinar. Yesterday, I also attended, and it is a really great one because very informative. We could get the real voices from the field. And thank all the participants and the TB partners for assisting Global Fund and the country in a funding request for Window 1. Actually, currently 23 countries with TB programs are under review by TRP just now. So the COVID-19 pandemic is having a catastrophic impact, not only on human health, but on the world economy and politics. This pandemic directly affects and kills health workers and the most vulnerable people, and threatens the progress against TB, HIV, and malaria. And the pandemic has been demonstrating stigma and discrimination, and a lot of issues related to human rights and among communities. The Global Fund is providing immediate funding up to $1 billion to help countries fight COVID-19, mitigate the impact on life-saving TB, HIV, and malaria programs, and prevent fragile health systems for being overwhelmed and collapsed. Under the grant flexibility, the Global Fund is enabling countries to use up to 5% of approved grant funding to protect health workers, test and treat patients, and control epidemics. Up to now, more than $100 million has been approved to 70 countries and 5 multi-country programs in these mechanisms. We are also working hard with other international agencies to secure and expedite procurement and supply of essential commodities like PPE, diagnostics, and when available, therapeutics, vaccines to fight against COVID-19. Through COVID-19 response mechanism, up to $500 million will be leveraged through the principle of country ownership and allow countries to request funding for control and containment to mitigate the impact on TB, HIV, malaria, and to support health systems, including laboratory network, supply chains, and community-led response. I believe TB community will work together to support countries to apply to these funding to safeguard achievement gained so far in TB and mitigate any negative impact on TB due to COVID-19. While assisting countries on COVID response, we should not lose sight on helping countries to submit quality funding requests for Window 2 and 3. We are expecting funding requests coming from about 40 countries in Window 2. Yesterday I learned many people also feel this is not just only loss, but also opportunity. So we should not consider this COVID response as a loss of our fight against TB, but we should think this is an opportunity to boost up our fight against TB. Because as you know, a lot of the response to COVID also quite similar and overlap with TB. So we should think about how to just piggyback or how to just boost up the TB response. It is very, very critical one. That is why today we want to hear from you what are kind of issues, but at the same time opportunities. So I'd like to once again thank the organizers for inviting Global Fund in the webinar, and thank you very much for all the participants who are actively involving and looking forward to fruitful discussion and actions for now and the future. Thank you. Luchika, over to you.
Thank you very much. And yes, it's a difficult momentum we go through, all of us. So let's see how we can progress together or make sure that we don't have too many losses on our TB and other diseases responses while we deal with this COVID. People are very affected by the lockdown measures, by the COVID, by the lack of services, by losing their jobs. People with TB are also used with a lot of stigma and discrimination. And at the point I was saying that they can share from their experience with people with COVID. But we decided to have this meeting opened to give the floor in the opening to our colleagues representing communities and affected colleagues. So I want to start by giving the floor to Timur. He's leading the work of TB people. He's also representing communities in the Stop TB Partnership Board. So I see no move in Timur unmuting himself, but I hope he will do it. He just did it. So Timur, if you can share in 5 minutes your thoughts with us about the situation we are finding ourselves in. Thank you.
Hi, everyone, and thank you very much, Luchika. I will try to make it in 5 minutes, though my short presentation was planned for like 45 minutes, but I will do somewhere in between like 30 minutes maximum. So I actually agree that in a way, every crisis is not just a challenge, but also an opportunity. But as a community representative, I'm more inclined to focus on the challenges side, especially because from the first days of the epidemic, we started hearing the reports about the difficulties people with TB are facing. And basically, like a few days down the epidemic, we heard that a person died in India because not being able to access the drugs and had treatment interruption. So this was really not a good beginning of this whole story about how COVID pandemic affects TB and access to services and treatment and diagnosis. So another thing was that we realized that actually it's not just the COVID itself, but also the response to the pandemic that was the problem. Even like the countries which did really well in terms of like putting forth measures to address the epidemic, they were really well performing in terms of addressing COVID, but in terms of other diseases, it was not necessarily so. And by introducing lockdown, basically what we had in result is that people were just not able to get to the clinic to get their drugs anymore. And even when countries did leave this caveat of like, okay, you can go out to visit a clinic, what it usually meant is that when person comes in contact with police, he or she would need to disclose which clinic they're going to and why. So there is definitely a confidentiality issue on top of that. So another thing that we saw was clearly another airborne disease was not helping, and the fact that we were trying to combat stigma related to tuberculosis for such a long time. Now having this pandemic, it made things worse. So we actually think that after the COVID epidemic is over, we may still face challenges, related to like how people treat airborne diseases, especially now that at least I see that in context of COVID, people more and more mention tuberculosis as the other big killer, which is actually, it started as the big killer, but now we're kind of moved to number two. And one more thing is that, well, we hope that the response that we see now globally will help the world overcome this pandemic, and we will see more and more countries going back to normal. But we realize that we will actually have to have some kind of assessment of the negative impact that we had, and see what's left behind after after the pandemic is over. The most recent information that we were getting is that in a few countries, big TB hospitals, which are used to treat people who really need to be hospitalized, these hospitals are going to be used for COVID patients, and this is certainly like very dangerous, because what happens to the TB patients who are there now? I won't name the country because I don't want to sound like I'm shaming and blaming, but what I heard is that in one of the regions in quite a big country, the hospital with 300 critical TB patients is now being passed to deal with COVID patients. So this is definitely something we want to avoid. We don't want to see a spike in TB deaths because of this. But let me finish with some opportunities. Even though I'm speaking as a civil society and as a community person, I don't want to sound too critical. And I think one lesson that we see, lesson learned that we see, is that actually there is a lot of money in countries that can be used. It was amazing to see how much countries, how much resources countries just showed and started using when responding to COVID, while they were actually not so enthusiastic doing so for TB. So we see that as an opportunity for some budget advocacy. We also see that the interest to some TB tools out there, including using expert machines for diagnosis of COVID, which will hopefully stimulate the interest to procurement of more gene expert machines, though it also has a downside. I don't mention the price, which is ridiculous for COVID tests using the gene expert machine, but the downside is that we don't want gene expert machines to be hijacked by other branches of healthcare system. And also, let's see what happens with BCG, whether research shows that it is as promising as it looks. So maybe there will be more investment into like having more of BCG vaccinations, even in countries that stopped doing that a while ago. So, again, our biggest priority is access for people affected by TB, is stigma and human rights. This is what we need to focus, and this is what we have been discussing as the 3 civil society delegations of Stop TB Partnerships. We had a few calls now, and we're thinking what we can do as jointly as civil society to mitigate the impact on TB response, on access to TB services for people affected by TB because of COVID, and how to actually use the opportunities that we have because of this to the maximum, even if challenges are overwhelmingly bigger than the opportunities. It doesn't mean that we should miss our opportunities. So thank you very much, and I thank you for your time and attention.
Timur, thank you very much, and thank you for your work, for your vision, and for your optimism. Despite of all the challenges, we should look at our opportunities. I fully agree with you, and we should never neglect communicable diseases, so-called old diseases. As we can see now, for the treatment of the new novel coronavirus, we are using some medicines which we used for the treatment of the patients with HIV, with malaria. We are looking with hope on BCG vaccination, and we are using the facilities which was built and the labs for the TB programs. So this is our reality, and this is for thinking how we should pay more attention at our the programs and invest more in the programs. With this, I am giving floor to other representatives of the civil society from other regions, to Harry Hosler from South Africa, member of the WHO Civil Society Task Force. Harry, floor is yours, please.
Thank you so much, Teresa and Lucica, for this opportunity to interact with the global community and to just give a South African perspective on TB and COVID and the advocacy issues related to TB and COVID. I want to start with a consideration of the burden of disease. And South Africa has an enormous burden of disease for both TB and HIV. It has the largest number of people living with HIV in the world, almost 8 million people. And the estimated number of people with TB was 301,000 in the Global TB Report in 2018. But of those, only 228,000 were notified and started on treatment. So we had 73,000 missing people with TB who were at risk then for becoming sick and dying and transmitting TB in their communities. And this is really very important because now we have an opportunity with the intensified work on screening for COVID to also screen for TB and to find the missing people with TB. There were also an estimated 63,000 deaths, that's 173 people dying of TB in South Africa every day. Over the last 8 weeks in South Africa, since the first case of COVID, there have been 207,000 people tested for COVID, 5,600 who tested positive, and 103 deaths. So over that 8-week period, 103 deaths from COVID and 10,500 estimated deaths from tuberculosis, 100 times higher. So it's really very important that we recognize the importance of TB and use this, as has been mentioned earlier, as an opportunity to find those missing people with TB and get them on treatment. We know that cough, fever, and shortness of breath are symptoms for both COVID and TB, so it's an excellent opportunity to integrate TB and COVID diagnostic services. We are fortunate in South Africa as well to have a very extensive platform of gene expert machines, and there's enough capacity to do dual testing. If we had the cartridges at an affordable cost for the Expert Express for COVID, we could use the existing infrastructure to do testing for TB and COVID on the same people who are presenting with symptoms. But the cost is too much, it's too high. It's $20 a cartridge, and the estimate from is that the company Cepheid would still make a profit if they sold the cartridge for $5 a cartridge. The cost of the cartridge must come down, and this is an important international advocacy issue. Contact tracing needs to be done in the households of people with COVID as for people with TB. And this is a great opportunity for us now to also meet the UN high-level meeting targets for TB preventive therapy amongst household contacts of people living with TB. So we can do then the household contact tracing and offer TB preventive therapy to those who are eligible. For treatment, we need to ensure to decant people from facilities and to focus on patient-centered care for TB. We should be doing multi-month dispensing. People can get the first 2 months of their intensive phase and take it home with some possible community support mechanisms, and then the next 4 months of their continuation phase with just having the initial visit, the 2-month visit, and then end of treatment visits to health facilities. If we can make it easy for people to access their medications at the community level. But we also really need to think about protection of staff who are providing TB services. And I'm talking about people in the health facilities, in the laboratories, but also at the community level. We have a large number of community health workers, and the Department of Health is not consistently providing personal protective equipment for them. We also must realize that for clinicians who are seeing coughing patients, if they're seeing a patient with COVID, a surgical mask is sufficient, but for people with TB and who are being investigated, they need N95 respirators or FFP2 respirators. But we really need to ensure access to PPE for our community health workers who are on the front lines. There are a number of behavior change elements that are required for both COVID and for that will help to also prevent TB. So the social distancing will help. Certainly, if people wear cloth masks when they go out into public, it'll prevent further transmission, and the personal protective equipment for health workers that we've discussed. I do think it's really important that we think about the human rights issues. There are a number of concerns that have been raised in South Africa, particularly with the restriction of movement and actual forced quarantine of some homeless people. I'm in the Western Cape that has almost half of the COVID cases of South Africa. And there's one shelter where people were brought actually against their will, many of them, homeless people, some of whom were either sex workers or people who inject drugs, and they went into a forced withdrawal from heroin, which is very painful. There was no access to opiate substitution treatment. So this is really a major concern. If people are addicted to heroin, they should have access to harm reduction services, to opiate substitution treatment, if they're going to be isolated. The catastrophic costs of COVID are really important for us also to consider. When people are informal traders or sex workers as well, they can't actually make money now. And there's a very high level of desperation and hunger. And we have to think about how do we provide people with at least the minimum amount of support and food so that they don't go hungry, and that we protect their basic human right to access to food. There's a lot of stigma, as Timur has mentioned, and discrimination. But these we know, stigma and discrimination are linked to fear, and often because of a lack of knowledge. Knowledge really is power, and I must commend, I know Lindiwe Mvusi, Dr. Mvusi from the Department of Health is on the call as well. And the department put out an excellent flyer on COVID and TB and HIV. And the title is Knowledge is Power. And it really is. If we educate people about what is COVID and how to protect oneself from both COVID and TB, then that empowers people and destigmatizes. And my last point is really that the one of opportunity. We've seen with COVID an extraordinary leadership, multi-sectoral collaboration, bringing together of governments and private sector and civil society to mobilize a huge number of resources, and also active surveillance with geographic positioning systems and high technology, real-time data. That is also what we need to use for TB. We need to sustain this kind of effort if we want to end TB, and we will be able to end TB and reach the global targets. If we use that kind of a mobilization of effort, multi-sectoral collaboration. Thanks very much.
Thank you very much, Harry. It was really very important. All the highlights were extremely relevant, and let's continue working all together as one community. And time is running so fast. We learned experience of the previous webinar because there are a lot of questions which we should respond, and that's why we agreed with Luchika. We'll limit our part and our intervention as much as possible. So, but anyway, I'll try shortly to present some ideas and information on the current situation. So. I hope you can see my presentation. So this presentation, just few slides about our current challenges and threats, and in the same time about how to identify the essential steps, the priorities, and how to go ahead without using as an excuse current situation, of course, taking into consideration, but in the same time, keeping in mind our commitments. So trying to go ahead. Okay. Just one more attempt to share my screen. Okay. Hope that it will work.
We can see this. We can see the presentation.
Okay, very good. So now if we look at the new threat which we have with the COVID and compare with the TB, what are the similarities and differences? People with COVID and TB show similar symptoms, very frequent, such as cough, fever, and difficulties in breathing. Both diseases attack, as we know now, primarily the lungs, and both biological agents transmit via close contact, and but of course there are differences, and they are very well known to the experts and community health workers and healthcare workers in general working for a long time with the TB. The incubation period from exposure to disease in TB is longer, and there is no such a quick onset. The experience on COVID-19 infection in TB patients remains limited, and we can, but anyway, knowing more about TB and the pathogenesis and the specificity of the development, we can expect poorer treatment outcomes, especially in cases if treatment is interrupted. In many countries, restrictions of movement and other measures and quarantine has been exposed for much of the population responses to the COVID-19 pandemic, and has unfortunately sometimes negative impact to the access to the essential TB healthcare services. COVID-19, as we heard from our colleagues from the civil society representative, provokes social stigma and discriminations in many countries. So it means that all measures should be urgently taken to ensure continuation of services for people who need to be provided by preventive treatment and curative treatment for TB, especially for multi-drug resistant TB. We are working, many groups and colleagues are working on the modeling, on the projections of the impact, negative impact of the situation on the TB epidemiology, on TB burden and mortality. Here is an example of some projections developed by our team, by the Global TB Program, and you can clearly see here on this example how the current situation, if it will be continued from 3 months up to 6 months and beyond, can negatively impact on TB mortality. If it will be relatively short, it will continue from 3 to 6 months. It will bring us back to the situation in 2015. If it will go beyond, the mortality will increase even significantly and will bring us back to the rate of the 2012. It means that all our huge efforts and advocacy and all the efforts at country levels could be minimized by this impact, and that's why it should be used for the advocacy, for first of all, for the continuation of the essential TB services. Of course, we should keep in mind our commitments, and we should continue moving forward, because 1.5 million deaths from TB means a lot. It's still #1 infectious disease killer, as Dr. Ren highlighted. So what are the key activities which should be undertaken now, and how we should continue our business, not as usual, but taking into consideration these new realities? First of all, we should think about protection of our TB staff, community health workers working with the TB, and all the measures should be in place. So prevention and limiting transmission of TB should be again taken into consideration seriously, and we should revise our approach and significantly change to the continuation of the services. The preference should be given to the patient-centered approach, to the community-based care with the minimizations of the visit to the healthcare facilities. Another point very important, to provide soonest implementations of the latest WHO guidelines on fully oral TB treatment for all drug-resistant TB patients, TB preventive treatment with a shorter regimens, but in general we have at least 5 options for the TB preventive treatment. And if in the previous period of time preventive treatment was somehow neglected, the meaning of it is even increasing this time, because you can imagine that households are now staying for a longer time together. Sometimes, especially when treatment of those members of the families who are seriously sick is interrupted, the risks for the others increases. That's why we should look at the available resources, including Global Fund resources, to provide TB preventive treatment and even strengthen it and to cover broader households. So the mechanism to deliver medicines and provide drug supplies at home should be also revised and urgently put in place. According to the differences in the situation, the drug supplies for 1 month, 2 months, and again, it depends on the situation with the drug procurement in the country should be provided. Use of digital technologies. We are requesting both WHO and Stop TB Partnership, please use our tools. We developed many very useful tools, and now it's time to use these technologies to provide continuation, to strengthen adherence, and for all other purposes, including reporting. Diagnosis of TB should be continued, but of course, we should think about testing for COVID for all our patients with TB, and we can use different platforms, including GeneXpert platform. TB treatment should be continued, and of course, proactive planning and agile planning should be in place. So you can see available resources for the information from the very the WHO website. You can find information on COVID and information notes on the essential services on TB. We developed it jointly with the regional colleagues from WHO regional offices, with the Stop TB Partnership, USAID, and other partners. Information is available. We are continuing responding to your frequent asked questions. We're in contact with you, and let's try to provide a continuation of our services together. I'll stop on it, and I'm giving floor to Luchika. Over.
Thank you very much. So, dear all, I have 5 or maximum 6 minutes to make my points. I don't have slides, so you guys better try to listen if you are interested, or don't listen if you are not. Reality is that as much as we try to put the situation that we are in now in a positive way as an opportunity, reality is that the TB response will be heavily affected, and we should be mindful of that. And I think we will see much more coming. You saw the modeling that WHO TB colleagues did, and Philippe and Catherine. We are working with our colleagues from Johns Hopkins, Imperial College, and Avenir to come with some additional modeling to add to this, and to show how big this impact will be. but the TB response will not do very well unless we are really doing whatever we can. And Dr. Ren and Sam and all of us made a strong statement to do whatever we can to support and ensure that the TB programs continue, that the diagnosis of people continue, that the treatment of people continue, and it will not be easy to do that. I want to be very pragmatic, so I will address my points in 3 buckets. One is related to the procurements and the global drug facility and all these things that are happening. As you know, GDF is providing the diagnostics and the treatments for the countries with resources coming from different donors, as well as obviously Global Fund, as well as domestic. We have teams in place monitoring the supply for first-line drugs and for second-line drugs. It is not easy what's going on with the first-line drugs as well, with all of them. There is reduced capacity of production, but also there are transportation issues. Transporting it by air is becoming very difficult, and even we know of a country that recently booked their own charter without realizing that the charter was not properly, equipped or to deal with possible inflammable goods. So it couldn't work. Can you believe it? So transportation is an issue. India is in lockdown, and it was announced that it will be in lockdown 2 more weeks. In this time, the productions are reduced. So what we do is we are very much in touch with every single country. A lot of big orders will be split into smaller orders. So be aware of that in terms of the drugs. We will try that everyone is receiving what's needed, but you have to be mindful that it's a huge amount of work that the GDF team is doing to make sure that that we try to ensure and avoid any stockouts. On the diagnostics, there are 2 parts. The diagnosis for TB, which is why we are all very interested. It must continue. We must ensure that not only continue the contact tracing and finding people and offering them access to proper diagnosis is essential for us to continue. The tools that we have for TB, for diagnosis, as it is right now, is the Cepheid GeneXpert machine, and hopefully MolBio if they will come to do that. These are our key tools, right? So that's why we need to make sure that these are used as maximum as possible for TB. Now, the GeneXpert cartridge for COVID. I fully agree with what Harry said and everyone. The cost is very high. Also, we need to be mindful before anything else that there are other tools for diagnosing of COVID. You have here a link that Denise shared on where you can see which are the tools that are available for COVID. Don't put all your eggs in a basket. And that means don't look as the GeneXpert as the main solution for testing COVID. First, because the costs are high, and there is indeed a consortium that is trying to see if the costs can be driven down, but also because the amount that will be available, because the request is so big and the countries need a lot, the amount will not be as high as our expectations. So please look at Abbott and Roche as the other tools. As GDF, we continue to supply the machines, the TB cartridges, and also the COVID cartridges. You need to be aware that indeed there is no need for a biosafety cabinet level 2 anymore. New data are coming, so the GeneXpert tests can be done without a biosafety level cabinet. Yesterday, we had the Romanian colleague who in the chat group shared that they are actually doing in Romania TB and COVID testing in the same time. They did 200 like this. They found 7 that had TB as well as COVID. So I think we need to be mindful of this. And I think it's a very good solution that everyone that is tested for COVID should be tested for TB as well. The next point that I want to make is on the fact that we heard from GDF, we saw that under pressure, countries are placing orders for very large GeneXpert machines, the one with 16 modules. We have a very few usually, maybe 2 orders per year with variable amounts on these machines. We are already at 7 orders up to now, till April, in 4 months, 7 orders, including only for these large GeneXpert machines. So it will be very important to be mindful that these machines are very large, so either people expect to have a lot of cartridges, which might not be the case because they don't have enough capacity to manufacture, or, people made some calculations that might be wrong. From GDF side, be aware that we are already, with some small delay, also supplying PPE, masks and gloves and the gowns and everything, and be aware about that. We can go into more details, but I'll stop here on these procurements and so on. The next one is around the fact that you see, unless we are ahead of the curve and with as much suffering that we have, because for so many years, TB, who is a respiratory airborne infectious disease, we didn't get the attention, we didn't get the funding, we didn't get the, COVID, we know for 120 days, right? I think Dr. Ren said something like that. And we have already 95 or something vaccines in the pipeline. TB is with us for more than 100 years. And we have, 2 potential, with a vision that we will have a TB vaccine done by 2028, right? It's pathetic. So now I just want to say that's why we need to ensure that not only that we don't lose in this with all our TB efforts being put, our words are being taken for COVID, sorry to say it. You guys, the doctors, are being pushed to do other things than tuberculosis. So we need to make sure that now that we are all moving in a way to the fact that we are becoming more virtual and online, use these opportunities with global fund applications, with this additional money, to achieve some of the, to push more for TB. I spoke about diagnosis, but also now think about improving your data collection system. We know that 80% of case notification is dropping in some of the countries because India has live data online available for anyone to take a look. I really call on, we should have that for all TB, that we will all should be able to quantify and be now up in hands, because we heard that Indonesia is on the same situation and probably in other places as well, but we don't have the way to see this data. The second point is, because we have opportunity now with Global Fund, move to some of the things such as artificial intelligence, such as digital technology, for X-ray readings, for monitoring treatment, for monitoring the activities through the communities. Use this to make sure that you procure laptops, subscriptions to internet, subscription to platforms online. Make sure that all these tools that are there available. And if you don't know which tools, check on our web page, because we developed a place, TB and COVID, where we put all the evidence and information and data and the notes produced by our partners. But also there is a paper on all digital and artificial intelligent tools that can be used. And also TB Reach is testing a lot of them and looking at that. I know TB Reach is looking also on pooled sampling for GeneXpert, and we will be able to share some of that very soon. The last, but the most important point, but it's such a long point, is it breaks our heart, the situation with the communities, the situation with the rights being broken, the situation with a lot of barriers that are seen by people with TB. We know that vulnerable groups are the ones that are reaching very difficult the services. And now being pushed in the houses without access, you can imagine that if somebody is at home, cannot continue the treatment, we will create, I am afraid, a lot of drug resistance TB with transmission not outside, but in the household, because we stay how many we can be over there. So we need to make sure in this Global Fund application that we ensure that nutrition support for the TB patients, that all this other support for people with, affected. Think about the additional health staff that are needed not only to have PPE, but they need to exist if we want to continue with the services for diagnosis and so on, we need to have these people in place and paid and remunerated, as well as volunteers, as well as other health workers. For civil society and communities, there is stigma associated to TB and to COVID. There is discrimination. There are gender barriers. There are a lot of tools that we developed with the partners, not just us, for stigma assessment, for looking at the rights of people. So there are a lot of things that are available. So think about deploying them and use this opportunity of additional funding from the Global Fund to put them in place for the TB people, but also for the COVID, as we said. The last thing that, so I'm ending here, we don't have too much time on this. There is a very good opportunity right now with the Global Fund that is putting some additional money into this COVID response. Eliud will explain how these funds will be accessed, but I'm also asking you to stay till the end, because we will go with Christian and Sahu into more details of what can be put in this special request through Global Fund for the COVID response to support the continuation of TB and HIV and malaria programs. And I know these proposals will be put by CCMs, but they will be funded. They will not go through too much drama and scrutiny. So if right things for TB programs to continue will be included there, you will get them funded. So we need everyone to be able to push and continue this effort and use this to ramp up and continue the TB services. Thank you very much for this, colleagues.
Great, Lucica, as usual. And it's absolutely crystal clear that despite of all the challenges, we have some opportunities, including financial opportunities. And it depends now on us how strong we'll be and clear our request and what we will propose as a solution for the solving this crisis, for the continuation of our services. With this, I'm giving floor to the representative of the biggest bilateral donor, to Dr. Sherry Vincent, Senior TB Advisor from USAID, to tell us about her position on this situation and what should be prioritized now. Sherry, floor is yours.
Thank you, Teresa and Lucica. It's a pleasure to be invited to speak here today. Really appreciate being part of this. So I think many things have already been said, so I'm not going to add on to what you all have talked about. I would say that USAID has been working really hard, and we have been allocated COVID resources and have been pushing those funds out to the field. But in addition to the COVID resources, we've also been looking at continuity of services and making sure that we are supporting continuity of our services for TB. So I think those are two areas we've really been working on. I would say on the positive side, and I think others may have mentioned this, but I think it is clear that the investments that we've made in TB have actually been an important platform for supporting things like COVID. In addition to, we've seen this with Ebola and AI as well, avian influenza. So I think this is important to say that these platforms are building the systems. They are important, as well as addressing, you know, the epidemic of TB and saving lives from TB. So, you know, that's the positive, is that, you know, all these investments that we've had over the years. I think the issues around really looking at what other people have said of losing the investments that we've made are, you know, a concern, obviously, of making sure all of these things that you guys have talked about so far are very concerning in terms of people not being able to access services, continue treatment. Obviously, that's the #1 thing. The the diagnosis has stopped for most part in terms of case finding. So I think that is a concern because we've invested a lot in this platform and people need to have access to these services. We know that every person we don't find that has TB is transmitting, and so it really is a snowball effect of what we would be seeing in the coming years. So I think this is really making sure that we're looking at this. I know people are talking about how TB and COVID, we know that CDC and WHO have all said that TB, people with TB are at more risk for COVID, and the opposite is the effect. People with COVID are more at risk for TB as well. And when we talk about endemic countries, we really need to be looking at this. And I hope that interventions are really moving forward where we're talking about this comorbidity and thinking, when you think COVID, you think TB. When you think TB, you're going to need to think about COVID. So I think it's interrelated, and we need to be thinking in this way because of the manifestations. I think that also looking at following the data, I think it's really important. Harry had brought up and really talked about the data, and I think we need to continue to remember the data. That, you know, more people are dying of TB, and so we really need to make sure that we don't start to see drug resistance, and really looking at where we need to invest our resources as we deal with this huge crisis of TB. So I really hope that we can look at this as, you know, a co-epidemic, comorbidities, can be thinking about TB and COVID at the same time, really building on our current investments, but also making sure we're not losing the investments that we've made so far, and that we're thinking of one and the other at the same time. So I would like to say that USAID is has support for Global Fund applications, either virtually or we have advisors in countries, we have projects in countries. So please reach out to your USAID missions if you need support on your Global Fund applications. We also have a web email address called USAID tbta@usaid.gov. So if you need support in terms of Global Fund application or looking at how you can adjust your activities or interventions on the continuity services during this crisis. So we really want to help countries to pivot and to adjust and adapt. But it's my pleasure to be here and to hear from the field and to participate in the discussion. Thank you.
Yeah, so thank you very much for this, Sherry, and for all of us, you know, to be here. We are going to a section now in which we will have an opportunity to hear from our few experience in the countries, because as much as we speak here and we try to guide, the reality is that those of you representing you know, governments and the TB programs, you had to move on, and a lot of you put already in place a lot of programmatic recommendations and guidance in order to ensure the TB program goes ahead in the COVID with goods and bads. And I would like to give the floor now to Teresa to introduce our first country.
Yes, it's probably one of the most interesting sections today, and yesterday we had also very interesting, we've learned from the experience from Seattle, from China, about how they managed to, during this crisis with COVID, to continue TB services. Now we are moving to another high burden country, to South Africa, and to the NTP manager, Dr. Lindwi Musi, and Professor Nazir Ismail from National Institute of the Communicable Diseases from South Africa. Dear colleagues, please share with us your experience, and please, floor is yours.
Okay, good afternoon to everyone. I'll start and probably Nazir will follow. Just from our country experience, first of all, I must say that in terms of the response, this has been mainly driven by communicable diseases following the outbreak response guidelines. But looking at the magnitude of the problem later on, the strategy then had to change and be more multi-sectoral. As a result, other government departments got involved. It was a ministerial program that was run. Now, the implications of that was that looking at the human resource constraints that we're currently facing, we had to then look at how we mobilize human resources to deal with the epidemic or pandemic. The first thing that was done was that staff at national level had to be deployed to support provinces. As I'm speaking, I'm in the province which I'm supporting right now. So in terms of the program itself, obviously it is affected. Secondly, we had to look at how we then also mobilize other resources. For example, community health workers were brought on board later on in terms of community screening. And these are community health workers that are working on both TB and HIV in the communities. So that part of work was also affected. And it has a lot to do with screening of contacts, household contacts, as well as supporting patients who are on TB treatment. And again, when it comes to data capturers, we needed data capturers to capture data on a daily basis so that it's reported routinely daily, right up to national level. And we had to pull data capturers at facility and district level to actually do that. When it comes to facilities, we needed more beds to accommodate COVID positive patients. And this meant that we had to look at facilities that are available. TB facilities were one of those, especially where we had spare capacity. So some of the TB hospitals were identified for isolating COVID patients. And obviously then we had to look at other options from there in terms of quarantine sites as well as field hospitals. Some had to be built where there were no other options. Now, accessing services for TB patients and the communities at large, because of the lockdown, this was affected. We've seen a reduction in terms of numbers, the head counts, for example, at facility level, the numbers of people who are accessing TB services, those that are already on treatment have come down, though in some of the provinces, there's arrangements for the patients to get their medications delivered to them in the communities, but this is not implemented in all areas. One other problem that has affected access to facilities, it's been mentioned that patients are scared to go out. And again, those that venture out, they are either informed by facilities that they are closed or they are stopped from accessing facilities on their way there. Transport is also a problem. It's public transport was also limited, so people could not even access, go to the facilities. Unfortunately, we also had not planned for such challenges, and therefore we do suspect that there are patients who've gone without treatment because of that. But we still need to look at and quantify that at this point. Again, contact tracing has been affected. Much as the teams, the community health workers are going to household, the priority now is to trace for the contacts for COVID, and they are not actually looking at TB. The medicines as well are a problem. We have developed a guidance on how to integrate TB and COVID, including other programs as well, HIV, maternal health, child health, and non-communicable diseases. But we haven't actually started implementing that at this point because of the lockdown. But as we begin to lift the lockdown, we're hoping that we'll be able to start doing that. The availability of medicines as well is a problem. We've had stockouts in some of the provinces, but it hasn't affected patients that much because they've been able to move stock around within the provinces and from other provinces as well. But there's still a lot of backlog with medicines, so we're a bit concerned that we might actually have stock out at patient level. The medicines for children, we're planning to actually start at the beginning of this year to use the new formulations for children, but we've had to then postpone that because of the problems in India in terms of the lockdown. We can't get those supplies. The same applies to rifampicin for implementing the 3HP. We've also had to postpone that. And unfortunately for children, we've had children not started on treatment now, which is a huge problem for us, mainly because of shortages of medicines for children. On integration, one of the provinces has actually piloted collecting both the swabs for COVID as well as sputum for testing for TB. We still need to review how that is working in terms of how much of TB have they diagnosed over the period. How they do this is packaging both the sputum bottle as well as the swabs in one laboratory bag so that people are reminded to collect both. We think that's a good practice that we could actually take on going forward. In terms of laboratory services, well, I'm sure Nazir will actually provide more information on that. But what we've seen, we haven't had any problems on the TB side. We've had problems on the testing swabs for COVID in some of the provinces. What we're happy about is that COVID at least has increased focus on infection control in hospitals, in our health facilities, and generally in communities. But the downside is that we're running out of masks, especially for there are shortages for health workers and both the N95 and the surgical masks. The other some of the challenges that we have also picked up were that in terms of quarantine, obviously people are complaining about human rights, as it has been mentioned, and stigma associated with that. And I think those are the challenges that we've been facing on TB as well. And stigma mitigation, I think, is still a weakness from our side. We have been trying to also increase social mobilization for both TB and HIV as well as COVID. Because of the lockdown, I think we have not really been successful in doing that beyond just distributing the pamphlets that Harry has alluded to. But we're hoping to use the radio as more effectively now, especially community radio stations, to send the messages out to communities. We are also trying to look at the best way of communicating to communities around coming back to health facilities and how we deal with the fears that they currently have to ensure that at least services are accessed by patients. I think the last part, or the other one on medicines that I think is also a pressure point is on the 4 drug FPCs. Again, availability of those, much as it is locally produced, the APIs come from Asia, and again we have problems with that. And we've had to come up with plan B in terms of how we ensure availability of that. When it comes to funding, as I mentioned, there's been an increase in terms of national budgets across all government departments, relevant government departments, especially health. We've also mobilized funding from the grants that are currently existing at National Health to deal with COVID, and we're looking at how we can then piggyback on those, on that funding to also address TB. Global Fund has hugely assisted us in that they've approved that the sub-recipients could also integrate COVID into their TB activities, especially in 5 of the 6 districts that we're focusing on for the Global Fund grant, which are mainly high TB burden districts, but they are also epicenters for COVID. And therefore, we're looking at integrating more in those districts and seeing what interventions would work along the lines of integration. To try and address access issues to facilities and ensure medicine delivery to patients, we're also looking at and piloting, hopefully we'll start once as we lift the lockdown, piloting innovative ways for medicine delivery, as well as adherence, looking at mHealth technologies. There was work already done in terms of adherence, which I think we'll just fast track now, since there is funding available to actually do that. Yeah, that is all I can share at this point from our side.
Hi, thanks, Lindiwe, and good afternoon and good morning to everyone. So just a brief summary from South Africa around the lab testing. I think the one important highlight I'd like to make is that, in these crisis situations, the existing systems are really stretched, and what you built in the past really informs whether you're successful or not. I think having a very strong lab infrastructure is key to being able to deliver good services. And I think South Africa has been quite unique in that sense. So if you heard Harry earlier on, we've done over 200,000 tests for COVID so far, and that leverages off existing systems that are in place, and that's the key thing. But specific to TB and COVID, I just want to share one quick slide with you all. And in terms of the impact of testing and COVID, so I don't know if you can see the slide in front of you. So let me just project it, sorry. So this looks at the testing of gene experts in South Africa in terms of test and number of cases detected using expert. And the first red line indicates where the social distancing was introduced. And the table on the right-hand side gives you a good indication of week by week what's happened in terms of test volumes, in terms of cases detected, and the positivity rates overall. And you can clearly see from the graphs that we had a massive decline in number of tests being conducted, and also a number of cases that have been detected as well. So about a 50% reduction from what we would normally expect, and about 1,000 cases being missed per week based on the social distancing and lockdown. So as Harry has pointed out earlier on as well, we've obviously had missing cases, and this has just become a lot worse, which is a problem because it's going to spread further as well. In terms of staffing, so I think the technology is there, the capacity is there. The availability of test kits has been a major challenge, and we've not only used expert, we've used all technologies available to make sure we can deliver the COVID testing as such. So it's not really an issue of testing capacity for TB, but more the issue of how COVID's basically taking on priorities, specifically around staffing. So I think Lindy has highlighted already, I mean, a lot of TB staff are being mobilized into COVID. I myself have been moved completely into COVID. So a lot of the TB activities have fallen behind, which is quite a problem on one hand. But when I look at it from an opportunistic perspective, is that I think TB people are probably very well attuned to respiratory infections. I mean, we're dealing with it for decades, understanding transmission, understanding the core principles around case finding, breaking transmission events, contact tracing, preventative therapy, etc., and personal protection. So I think from those perspectives, that has been really great in terms of being able to inform. I mean, when I look at the response initially, it seems to be misdirected, but I think a lot more TB people have got involved. It's become very more directed around a strategic approach to dealing with the COVID epidemic. So I think TB people have a big role to play, both lab and clinical. The one thing that we've noticed in the past week was a mini outbreak of healthcare, of actually lab staff, 15 lab staff in Cape Town that have been infected by COVID at the Groote Hospital in Cape Town. And, you know, it's not related to, which is surprising, it's not related to them getting the infection processing COVID sample. This was actually staff in the hematology lab and clinical pathology. And the story behind this was essentially, although most of our like academic labs and hospital-based labs are within hospitals, so they walk through the same hospital, and there was a mini outbreak in Groote Hospital, and the lab staff that are sort of moved through that hospital have been infected and transmitted it as well. So it really has impact not only on clinical services, but also lab services as well. And again, the issue is not just protection in the labs, but a generalized community protection, because they're going to get it at home or elsewhere as well. So just the one I think I'd like to end off with is, I think when we're looking at this whole cascade of care that's taking place for COVID, I mean, they're talking of cascades now in South Africa for COVID. And it's very much like what we've been doing for HIV and TB. So I think there's a lot of lessons that have been translated into the programs, and I think it's actually making a difference for them to understand how to sort of ensure linkage to care, because not just diagnosis, it's treatment, etc. But I think we should, it is the right time to highlight that we need to get a lot more money into TB, because it's a dual infection. And there's two concerns that we have in South Africa related to TB and COVID. Something we've seen for influenza and TB. Number one is that increase in mortality, so excess mortality related to when people are infected with both influenza and TB, and it's very likely to be true once we see COVID and TB. So excess mortality, also those with post-TB lung disease. The second thing that we've observed recently when we're looking at analysis of influenza and TB recently is that there seems to be a very close association between spikes in testing in the winter periods and followed by about a 6 or 8 week window in which we get a spike of TB cases, whether that's related to immune modulation or increased transmission 6 to 8 weeks earlier. But we definitely see an association between the influenza spike and TB spike in cases. And we're likely to see a lot more active TB cases related to COVID. So I think the combined approach of making sure that we can screen and isolate both TB and COVID is going to be critical to control. Okay, that's all I have. Thank you.
Thank you very much, Nazir. So we move from South Africa with a lot of very rich information, I would say, and thank you very much, Lindiwe, for a very, very clear description of what is happening. A big task comparable to the big burden that you guys are facing. And Madam, great job given the conditions. I am moving now to another colleague of ours from Brazil. To see how is the TB program going on in Brazil, and any challenges that you have or face there. Thank you, Denise.
Hi, Lucica. Hi, Teresa. Thank you for the opportunity to learn about the countries and to share what we are doing here. As you know, Brazil is facing now a political crisis. So we are trying to keep the TB activities in place. And I'm sure, can you see the PowerPoint? Okay, so the first thing we observed is the reduction of human resources. On TB program at the federal level, we lose almost 50% of the people to be in home because some morbidities and one person is pregnant. And from state level, 50% of the people from the TB programs are in home. And in some states, we have 100% of personnel in home, for example, as Rio de Janeiro. The all team, the all people, 15 people are working in home. In the municipality level, is a sub-state level, we are doing a survey, and we expect to have the response until the later May. The major problem for us is drug supply. And for example, for the rifampicina, isoniazid, pyrazinamide, and ethambutol, we have a stock out from later May. We are, because we depend from the Chinese and the Indian manufacturers. So we are trying to have an emergency purchase through PAHO, Brazil, to try to solve the problem. And we expect to have these drugs until the beginning of June. But if it's not happening, we are trying to donation and many things, but we have, I think this is our major problem. For the diagnosis, we compare the cases notified in January, February, and March of this year with the previous year. There is no difference. Maybe because the COVID pandemic hit the country in the second half of March. Maybe this no difference represents the beginning of the pandemic. We recommend, because to handle all samples, respiratory symptoms considered as COVID risk. So we are recommending to manipulate the samples under biological safety cabinets. So we have to reorganize the network, especially because of the transport of samples. And now we are purchasing 200 cabinets. So we expect to solve this problem until June. And I saw some recommendations it's not necessary to use these cabinets, but for example, in São Paulo is the most important state on COVID, and they are doing different recommendations for the network. In the cities where there is no transmission of COVID, the cabinet is not obligatory, but in São Paulo city, where the epidemic is very strong, they use all samples and manage under biosafety cabinet. The Brazilian government is, we will use the TB expert machines to support the COVID diagnosis, and the Brazilian government is bringing more 60 machines with 4 slots, and a 600,000 express COVID cartridges will arrive in May, and we are shared our network to support the COVID diagnosis. In terms of we become the DOT more flexible, using all the technologies, video calls, phone calls, WhatsApp, to keep the care of these patients. And in terms of virtual meeting, we are trying to keep the teams very close. So we have monthly ordinary meetings, is always by internet. And we organize the extraordinary meetings with the state level. Now is monthly, before it was every 6 months, but now it's monthly to see what they are facing, and to see how we can, from the national TB program, we can help them. And for civil society, we just done one meeting 2 days ago. The idea is to have monthly to identify how the TB program can help them. And we will start in the next week web with the expert to discuss diagnosis, to discuss lab recommendations and other issues. And for the next steps, we starting to linkage the database of the COVID database, NTB, DRTB, NTB, HIV database, to see if COVID, what's the influence of COVID in our patients. we are now investigating 5 deaths of TB patients due to COVID-19. One is confirmed, but we need to confirm more for deaths in 6 weeks. We have these 5 deaths. In terms of research, we are financing respiratory symptoms in emergency room, TB and other respiratory virus prevalence. And we are financing research about BCG revaccination on healthcare workers to protect against COVID-19. And we have one social vulnerability study in progress. So the idea, we plan to discuss with the PI to adapt this study to include some questions regarding TB and COVID. And we made some folders, some flyers we send it to folders to healthcare workers about TB management, what they have to do in terms of drug dispensation, abandon, DOT. And we have one FAQ for patients about TB and COVID. And we have another folder for the laboratory people to see how they can manage the samples. And if it's not necessary to use the safety cabinet, we can produce another one. Remind you that São Paulo is doing different recommendations, consider the epidemiological context to do this recommendation. And we have another folder about the social protection for TB. The Brazilian government is providing some extra money for people who are under vulnerability, and we are including the patients. And this folder we will release next week to help the healthcare facilities to identify the TB patients under risk and to refer to social assistance. But this is already read, and we intend to launch in the next week. I think that's all.
Thank you very much, Denise, for your very good comprehensive presentation. And I think you can click on stop sharing. And
yes.
Yes. Thank you. Thank you very much. I would like, before I'll give floor to another speaker, time is running very fast and we have very important topics to discuss, and I would request you try to be brief. And also you touched one topic on BCG vaccination. I would like to refer you to the scientific briefs released by WHO on BCG vaccination. Our position for now is clear that WHO is not recommending to use BCG for the prevention or from COVID, because we have no evidence proving that it will be effective. But in the same time, there are at least 3 ongoing trials. We are staying in touch with the colleagues, and we will, as soon as possible, some new data will be available. We will keep you informed on it. So thank you very much. And I'm giving floor now to Dr. Askar Yedelbaev, a regional TB advisor from WHO Euro, for sharing his experience.
Good time of the day, everyone. Thank you very much, Teresa. Thank you very much, Lucica, for this opportunity to present the experience of the WHO European region and the status of where we are. So the WHO European region still remains the epicenter of the COVID-19 epidemic in the world. So with more than 1,400,000 cases and 135,000 deaths. So as of today, out of 53 member states, 52 reported cases of COVID-19. And the recent state was Tajikistan. The only one country that was not reported is Turkmenistan. So the region is at different stages of COVID-19 pandemic, with higher numbers in the western part of the region and lower but growing burden in Eastern Europe and Central Asia. So, and as you know, the WHO European region is having and experiencing a high burden of multi-drug resistant tuberculosis, with estimated number of 77,000 cases annually. And the proportion of drug resistance among the new cases is also high, is more than 18%. And among previously treated cases is 54%, which is times higher than the global rates. Also, another burden that our region is experiencing is the HIV, the rise of HIV, and the prevalence of HIV among the TB incident cases is 12% as the last reported data. So the challenges in our region are similar to others, and they were described by presenters today. So most of it is like our TB patients are vulnerable for the COVID epidemic and for COVID infection. And the risk of acquiring this disease is high, especially in congregated settings like hospitals and prisons. And it's also a risk for the acquiring COVID from health providers and for medical workers who are treating these patients, as well as the administration of these health facilities dealing and working in these difficult circumstances. So also another challenge that we foresee after our work and dialogue and constant dialogue with countries is the increased workload on medical workers, the laboratory personnel. They also, some of them are reporting and experiencing the problems and challenges with availability of PPEs and the tests of COVID-19. Most of the NTPs in our region are involved in the response to COVID, and some reported that facilities has been reprogrammed to the COVID response, hospitalizing those with suspects or patients with confirmed COVID, and which is also increases the risk for the nosocomial transmission of infection. Saying that, some of the countries reported that they started discharging patients to the outpatient settings. And this is another problem, is that the massive discharge of patients to the outpatient settings where there is a lack or to organize the proper directly observed therapy or treatment monitoring throughout the duration of therapy. This poses risks for the continuity of care and to the development of the unfavorable outcomes and due to the treatment interruptions. So the problem also that we have seen through the dialogue with countries is that there is a possibility for other programmatic disruptions. Is this transportation of Sputnik between the regions to the regional level labs, to the national level labs from the regions. So also the biosafety for the during this use of GeneXpert cartridges for the COVID-19 testing, if the COVID cartridges will become available. So the risk is that the GeneXpert machines can be reprogrammed for that testing by countries, and there is a growing demand that we have seen in our countries. So also there is the monitoring visits from the national tuberculosis programs to the regions as they routinely were doing is also currently disrupted. Trainings aren't possible, supervision visits, and monitoring and provision of the psychosocial support. This poses significant challenges and problems to the countries. Nevertheless, but from the regional perspective, and I'm thankful to our colleagues from the Stop TB Partnership, from the Global Drug Facility, to their collaboration on monitoring the situation with a procurement of diagnostic materials for TB, and also for the medicines for tuberculosis and drug-resistant TB. And as of now, none of the countries reported major risks so far. And we also are monitoring together the availability of stocks in the countries for diagnostics and medicines, and none of the countries reported that, but it can be affected, as what has been explained, with if the production will be hampered. So another challenge that we are facing in the region is the provision of the technical assistance through the in-person country missions, which is problematic right now with the country's lockdown, but also we are providing and doing our best to provide the best support to the country through their virtual and remote ways, but sometimes it's also not possible. So what has been done in the region so far? We as one WHO are having the regular coordination with headquarters and with the country offices on our efforts and in the best of supporting countries. We collaborate, as being said, with Stop TB Partnership and the Global Drug Facility, the Eastern Europe and Central Asia Group, on the procurements and the stock out and the possible stock outs in the countries, and coordinating efforts on that. We also are providing countries with the technical support on the revision of the country funding requests to the Global Fund applications for the windows 1 and 2. And so far, we supported 3 countries who applied from our region. It's Tajikistan, Kyrgyzstan, and Azerbaijan, and supporting countries for the window 2 application. Kosovo, Ukraine, and Moldova having the TB component in their requests, and also supporting countries with reprogramming of their Global Fund grants and to the COVID response. And currently, 16 countries in the WHO European region are implementing the Global Fund grants for 2017 and 2019 allocation period, with a total amount of $229 million. And based on the Global Fund COVID response mechanisms, approximately $23 million are available in the region to use for COVID-19 response. And as of today, funding requests for COVID-19 response has been approved for 70 countries worldwide and 5 regional grants. This includes 11 countries from the WHO European region. It's Albania, Azerbaijan, Belarus, Georgia, Kyrgyzstan, Kazakhstan, Kosovo, Moldova, Romania, Tajikistan, and Ukraine, with a total amount of $3,711,000. Most of the countries are using 5% savings mechanisms, thus there is no negative impact on ongoing Global Fund support programs observed. And activities under the Global Fund COVID-19 response include, but not limited to, epidemic preparedness assessment, laboratory testing, sample transportation, use of surveillance infrastructure, infection control in healthcare facilities, and information campaigns. So we are working with countries closely and providing as support through our regional mechanisms. As we have seen the reports from countries, and it's growing on the co-infection of TB and especially drug-resistant TB with COVID. So we organized a bilateral medical consultation concilia with support of our experts from the Regional Green Light Committee. And so far we have been successfully done some medical concilia for 2 countries, Ukraine and Azerbaijan, and the number of countries growing. We are also discussing with countries through the regular calls with everyone, especially with those high burden for MDR-TB, on the best possible support, which is possible in these current circumstances, and describing, which was already described. And another mechanism that what we are using is that in the WHO European region, we are, before COVID, initiated the regional initiative on introduction of fully oral modified shorter treatment regimens for management of patients with MDR-TB under operational research condition. And this regional initiative is covering 11 countries of Eastern Europe and Central Asia. And of course, COVID brought its implications to the implementation, but nevertheless, the initial workshop visits that we were planning to the countries were reconverted to the virtual mode. And so far, we successfully conducted 3 to 5 virtual day workshops in 5 countries. The first country was Belarus, Azerbaijan, Uzbekistan, Moldova, and Armenia. And this is, as of today, we're continuing and planning to cover all 11 countries. And that includes the adaptation of the study protocols to the country conditions, discussing the eligibility criteria for inclusion into this operational research and ongoing support that is needed for the countries. With also in the WHO European region, with the, through the regional mechanism as European Laboratory Initiative and the core members, we developed the rapid communication on the role of GeneXpert platform for the rapid molecular testing of the GeneXpert COVID cartridges, and using other mechanisms to regional mechanisms to continue support. We're still planning the technical advisory group on tuberculosis in May, planning to train the new GLC consultants on the upcoming new guidelines released by the WHO on drug-resistant tuberculosis. And also the big emphasis is being placed for the video observed therapy, and we are planning the assessment and doing the assessment on the digital solutions for tuberculosis. And we consider this not as a video DOT, but as a video treatment support for patients. Thank you.
Thank you very much. Time is our biggest enemy, and yesterday it happened the same to us because there's much richness of what's going in the countries, and we think it's very useful for everyone to hear what's going on and learn from each other and see how easy and what's available in these times. But I want to really move very quickly now to two colleagues, and especially, Eliud, the senior advisor for TB at the Global Fund that quietly was here with us from the beginning. And Eliud has a lot of very rich information to share with us, Global Fund funding opportunities. And I know Lindsay, I think she's with us as well. So it will be good if after Eliud, Lindsay, you share your points right away without me interfering. So Eliud, the floor is yours, and sorry for the delay.
Thank you, Rishika, and also Teresa for inviting Global Fund in this. And good afternoon, colleagues. Good evening for some of you. I'll be very brief in the interest of time, and we will be happy to take your question. Lindsay, who is my colleague, will also respond to some of your questions and probably some of the questions already in the chat. So in terms of the Global Fund support, I think it has already been alluded by Dr. Sam, that this is the money to support countries to mitigate the impact of COVID on 3 diseases, but also to help countries with their COVID response and also strengthen their community and the health system. Currently, we have 2 mechanisms which provide this support. In total, country can apply up to 10% of the 2020-2022 allocation. We have flexibilities through the grant, which was announced in March, and many countries have already applied. And it was highlighted by some, already 70 countries have already benefited from this one. More than 100 million has already been approved. And we have seen countries actually applying also to interventions which are COVID related, but also supporting TB program. We have example of countries such as India, where they've applied for medical devices, which could help laboratory, but also help TB laboratory, and also other countries applying, buying digital mobile X-ray to use for COVID, but also using for TB interventions in their country. I think what is critical for this one is that we don't have a program split for this allocation. So it's important for TB program managers to be proactive in terms of this one. Look at your program, make sure that essential TB services are maintained, but also be able to apply for interventions, work around interventions if there is a limitation due to COVID pandemic in your country. So that will be critical. And in terms of the support, the immediate support, priority will be about 3.25% of the allocation that will be provided immediately after the application, and the rest of the funding will be provided if there will be more funding coming for that. The other important component of this support is that you could apply also for the laboratory support. And in our application form, which is a very simple application form, there's Annex 2, where you can indicate the amount of laboratory supply which you would like. At the moment, we support the automated platforms, and we have listed the 4 platforms which will provide support. We are working as part of the consortium together with WHO and other partners to work around getting this test. We know there's a global shortage of this test, and many people have seen even questions where they would like to procure this test, but it's difficult to get. So we are working as part of this consortium, discussing with manufacturer directly, and we'll be able to get this test and make them available to the countries. Due to the shortage of the test, it's not possible to provide all the tests which you request. So there's a table which you can indicate the amount of tests you request from your country, but this will be provided based on the availability of those tests. I think I'll stop there because of the time interest. And Lindsay, maybe if there's anything you would like to add or question which you would like to respond, yeah, so you can take it from there.
Sure. I actually wanted to respond to one of the questions that was in the Q&A earlier that related to the questions around savings. And do you need to wait until savings, until after the expenditure has happened to identify the savings? The grant flexibilities that are available relate to the current grants from the 17 to 19 period. And if savings are already clear, you can apply for up to 5% of using those savings to have the COVID response, or you can opt to reprogram, but certainly there is no intention that we would want to deny any community essential supplies and drugs or etc. So that I want to make sure that we fully understand that the intention is not to reduce the current HIV, TB, malaria programming, and certainly in the case of TB, not to reduce any of the essential supplies that are needed for the current program. If anything, we want to complement and add to those with the new funding that is available. And this new funding in the response mechanism is not deducted from your future allocation. It does not affect your funding for the 20 to 22 period. It is incremental funding that is available now that will be a top up to your current grant. Are there any other questions that anyone else wanted me to respond to at this point?
So thank you very much for you both, for Elliot and Lindsay, short and clear and smart. And I'm sure that there will be many other questions, and our colleagues from countries will reach you directly. So, but it's a very good initiative and very good opportunity for the TB community to attract attention to the essential needs and to apply for this new grant. So I am giving floor now to the colleagues from WHO and Stop TB Partnership, to Dr. Christian Gunnerberg and Dr. Sahu Suvanan, to summarize our requests, joint request as a community to the Global Fund, taking into consideration this additional opportunity, how to effectively combat COVID and in the same time effectively provide continuation of TB services and protect those who are most vulnerable.
Yeah, thank you very much, Teresa. And what we've basically decided in the Situation Room, our different partners, is to discuss what are the critical areas that we should encourage countries to submit for the COVID response, to make sure that TB is represented and TB is not forgotten in the national ask from the Global Fund for this 0.5 billion. So I will now show, summarized in 2 slides, what we had suggested. And let me just screen. And I've prioritized this in terms of making sure that, first of all, obviously, we want to have TB diagnosis, but for TB diagnosis, we need personal protection, PPE, and infection control measures. So training and capacity building and lab biosafety for all staff in all facilities, and the equipment for testing patients for presumptive TB and or COVID. Without the staff feeling safe, there will not be conjoint testing for COVID and for TB. We need to support the development of infection control plans covering the COVID needs as well, along the lines of the WHO TB infection control guidelines. We need respirator masks, goggles, gloves for COVID, as well as for use in TB. I saw on the chat that hand washing facilities, simple ones where they are not present, should be put into clinics. If you can do that in low resource settings, things like that might also be very useful. Basically everything to support infection control and PPE. We also need to consider the human resource. We know that staff will be under stress, that staff will be off sick or in quarantine themselves. So we need to consider in the funding additional human resource costs needed for testing during the COVID-19 crisis. The second issue is medication. We've already heard that there's threat of stockouts and of supply chain problems. So we need to be clear that also in the funding, if needed, drugs for changing, the TB medications for drug-sensitive TB, but then also, if possible, giving people more supply when especially when they're at home in lockdown. And this in itself requires more stock than is usually there. And that needs to be considered. And especially if this COVID is going to be with us for a longer period of time, and there may be repeated lockdowns or whatever, and people are socially isolating, that basically we need to make the drugs more available to patients in their homes and adjust for that. Also, if possible, this is an opportunity for changing to the injection-free MDR treatment for all patients, because with injections there needs to be contact, and the oral regime, which is what is recommended by WHO anyway, would be a useful end to that. In terms of diagnostic support, we believe that we need to support the country choice of COVID testing platform. And what that means is that when the country has decided that it's going to be expert, then of course we should be supporting the COVID cartridges and the expert machines for the COVID. If it's other form of COVID testing, and there have been the caveats thrown in throughout the conversation that perhaps, especially in the beginning, the scale up of the expert is not going to be so rapid, so quickly, and there's other forms of COVID testing which should be supported. Make sure when you're at country level that you know what your country's strategy is, and make sure that the Global Fund funding supports that strategy. We should support, whatever is the strategy, we should support the additional purchase of GeneXpert TrueNATs units and consumables to cater for TB testing wherever COVID testing is taking place. I just wanted to point out that we have particular outbreaks in prisons. We have particular outbreaks in old folks' homes. We have a high rate of COVID in the elderly, and particular in the men. Well, these are all risk factors for TB. So there's a lot of sense to co-test TB and COVID presumptives at the same time. So we should try and work towards this, particularly as the situation continues and stabilizes, supporting additional expert TrueNAT machines, consumables to cater for TB testing. And we should also make sure that if you're going to purchase expert machines, make sure it's the 10-color optic instrument, as these allow tests for resistance to azonized fluoroquinolones and aminoglycosides as well. And so that we can have XDR testing in the future, because at some point there will be this cartridge which will be is likely to allow us to test for the second line drug. So make sure you make opportunistic use of the fact that we have this issue in order to make sure that the TB long-term interests are preserved. Specimen containers, appropriate packaging and transportation for both COVID and TB specimen is essential. And also, as already mentioned, in India, invest in digital x-rays for both TB and COVID. We think that virtual care and digital technologies are essential. Software for data capture from mobile phones, for contact tracing, case management, dashboarding for indicators of performance, medication adherence support, e-learning for health workers and other caregivers, lab data management, stock management, quantification and logistics, community networking and feedback apps. All of this is something we should be considering in the support for this epidemic. Digital monitoring systems, national level real-time data systems should be established for TB, including for contact tracing, treatment monitoring, and preventive treatment. COVID experience is great for real-time data and contact tracing systems. They need to be used for TB everywhere. We should invest in systems of virtual meetings and trainings, and we have examples in Brazil of that happening already. And we need to support operational research for artificial intelligence on digital X-ray machines for TB and for COVID, which is ongoing. Investment to improve community health systems. This is important. You need to ensure that these systems don't collapse, and where possible, make some of the financial support available for keeping these going. Contact investigation. I saw Ken Castro's comments on contact tracing and have changed it to contact investigation as he suggests, because it is more than just tracing. And as he mentioned, contact tracing has a little bit of a pejorative sound to it. COVID, as well as active TB case finding and finding people to give tuberculosis preventive therapy, and consider the use of digital technology here. For instance, the Prevent TB app, and the partnership also has apps, and we can provide links to all of these beyond this when we're putting this list to countries. We also have to consider now that TB diagnosis is basically being stifled, and immediately post-lockdown, we need to look at activities for re-establishing diagnostic facilities, reviews of HR situation, and additional hiring if required, expecting some health worker shortages during continued COVID pandemic. And it's interesting that the Global Fund has put their support in 2 stages. So particularly for the second stage, we should be considering the long-term implications of what is happening at the moment for TB diagnosis. Sahu, I hand over to you for any additional comments on this.
Thank you. Because of the time constraint, I will just be very brief. These were discussed and identified between partners in the situation room. So we are ready to support these interventions when they are put forth by countries to Global Fund. One thing that I would like to mention is that this is a great opportunity. We always talk about the COVID pandemic as a problem, but this is a great opportunity to turn digital, to change our systems for diagnosis, to change many things in the care system, the laboratory system, the community system, and this opportunity we have to seize. One thing related to this, very important for people in the countries and partners, this all discussion will happen at the CCM level. The CCM is supposed to propose this to Global Fund. We have to see that the voice of TB in the CCM has to be there, strong and bold. And the NTP managers and partners need to be very bold in suggesting what they need for the TB program, because this opportunity is great and will not come back. We have to remember that there is a deadline for this funding. It has to be used by June 2021. So we need to act fast and put in things that we have dreamt of in the past has not happened. This is a great opportunity. Thank you.
So thank you very much, dear colleagues. We have so many topics to discuss, and it's obvious both for me and Luchika that we need more time, and probably we will try to organize these webinars more frequently. I would like to thank all the participants and from WHO, senior leadership, from Stop TB Partnership, Global Fund, and all the regional and country representatives. It was a great learning from all the sides, and I hope it will be continued. And we should use this momentum. Yes, we are facing hardships. All the world is facing the hardships problems. And the smartest will try to continue and try to do the best to convert our challenges into the opportunities and provide continuation, because continuation means life for our patients. Thank you very much. Floor is to you, Lucica.
Yeah, so thank you. Thank you very much. It's impressive. We stayed more than 200 for 2 hours here. I would like to say that even though we rushed through the last half an hour, there were the country experience, and then this last part of the guidance is very important. And for those of you that have an opportunity to really access the Global Fund funding, either for the new round, but also for this COVID, the TB, HIV, malaria response, please do it. We will be here to support you, because it's a great opportunity that Global Fund put in place these financial resources that are actually coming from the savings of the country. So these are not additional money. So it's better to use this in a proper way, that we don't regret that we didn't use it. And it might not be easy at the country level. Very often the CCM might go ahead and you might not be even involved. I don't know, it depends on the countries. The TB program managers sometimes are in the dialogue. Civil society affected by TB might be in the dialogue or not. So please follow up on this, because it's now, between now and end of May, when these applications will be made. And if you need anything from us, to share more, to support more, but also to nag around the Global Fund that you didn't know, that you are not involved, all these nice things, don't hesitate to tell us, because we will be here to support you, all of us. Thank you very much. And have a great weekend.
So, dear colleagues, with regard to your questions you've shared, our teams try to do their best to respond to your questions online. In case if you feel that you didn't receive appropriate response, please share your email and we'll try directly to you respond to your question. There were a lot of very important questions raised, and we will continue working. We'll continue collecting information from the countries and inform the senior leadership, the country officials, our WHO leadership about some burning issues, about the critical disruption of the services for making decisions. And actually we're already doing this, and Stop TB Partnership is promoting this information heavily. We are sharing during mission briefings, during meetings with the country officials at different levels. And also we should share our best practices and experience, how in this situation we are providing our services. So we can't choose the time where we can live and work, but we can choose our position, and we should try to do our best to be proactive. Thank you very much. Stay safe, and we are staying in touch with you.
Thank you. Bye-bye.
Bye-bye.
Bye. Goodbye.